Thank you, sir, and thank you for the introduction as well as excellent case presentation, which has really started the ball rolling. So I would be sharing my slides. Hope the slides are visible.
Yes.
Thank you, and I would like to thank the Endocrine Society of India as well as the organizers for giving this opportunity. And we have an excellent set of discussions yesterday and today, and this is again a very interesting and rarely talked about aspect of endocrinology, that is snake bite and endocrine disorders. So in India, we have about more than 200 species of snakes, and the four species are which are the most poisonous and which cause the maximum amount of morbidity and mortality. These are known as big four. Among them, we have the viperides, which are vasculotoxic, that is Russell viper, and as you can see, the saw-scaled viper. And you have the Elapidae, that is the neurotoxic snake bites, and of them, the most famous is the king cobra as well as the common krait. But the Russell viper has a wide distribution across the Indian subcontinent, including India, Sri Lanka, and Burma, where the presence of snake bite is very common and these complications. So in India, there are more than 200,000 snake bites reported annually with about 50,000 deaths. And snake venom is a mixture of protein, peptides, and carbohydrates. And the effects of the venom depend on the chemical composition, the delivery, the amount which is delivered, and the type of the bite. The neurotoxic snake bites, especially like cobra and krait, have mainly neurological manifestations, whereas viper venom has mainly procoagulant enzymes which activate the coagulation pathway, and this leads to the microthrombi deposition and DIC and activation of fibrinolysis and bleeding. The viper venom also has metalloproteinases, and which is known as hemorrhaging, and this may also lead to damage of the vascular endothelium, leading to vascular leakage. And there is also the viper venom can lead to the damage of and impairment of platelet function. So viper venom basically leads to thrombosis and spontaneous hemorrhage, and this leads to ischemic infarction and hemorrhage in different organs like adrenal and the pituitary. And this infarction is because of DIC and peripheral vascular collapse, as well as spasm of the vessels. And the hemorrhage is, as we have talked about, because of decreased platelet function, decreased clotting factors, as well as fibrinolysis. As you can see here, there is this bleeding in the pituitary stalk in this autopsy sample, as well as you can see in this adrenal gland just above the kidney, you have bleeding in the adrenal gland. And if you see the histopathology out here, there is this fibrin clots along with this yellow colored cells, which are the RBCs as well. So the most common autopsy finding in the pituitary are ischemic necrosis with hemorrhage along with microthrombi. And the endocrine manifestations can be pituitary and rarely posterior pituitary dysfunction, adrenal involvement, dysglycemia, electrolyte imbalance, and type 4 renal tubular acidosis. Now, the pathophysiology of hypopituitarism is quite similar to the pituitary apoplexy in an enlarged gland with limited vascular supply seen in Sheehan syndrome. And there you have the vasculotoxicity from the venom, which leads to the capillary leak, which I have discussed because of the damage to the endothelium. There is pituitary edema and swelling. Along with that, the toxins in the venom leads to direct stimulatory effects on the pituitary cells, leading to increased TSH, ACTH, and GH growth hormone. And along with that, with the engorgement of the pituitary, there is decrease in vascular supply because of DIC and induced thrombi, because of hypotension, because of increased ICT. And as we are all aware, there is a compressive effect by the in the sella and with regards to the capillary leak that leads to more of a compressive effects. And this leads to the acute pituitary damage. Now, there is also a postulated, not yet proven, slow autoimmune damage as well, which is seen akin to Sheehan syndrome. And this is probably auto-antibody mediated slow destruction of the pituitary. And this occurs because of uh, disclosure of the sequestered pituitary antigens by the initial small acute damage to the pituitary. Now, there is both anterior as well as posterior pituitary dysfunction, both acute, as we have discussed, as well as chronic hypopituitarism. And hypopituitarism is, though mainly seen in Indian subcontinent and has been reported as well as Burma and Sri Lanka, probably it is not very well picked up, and a lot of them are undetected. And this can occur very early, within weeks, acutely, as well as it can be detected very late, about even 10 to 20 years down the line. The delayed hypopituitarism, which leads to maybe because of a late diagnosis of acute anterior pituitary insult, or as we have already discussed, maybe because of slow and progressive destruction of anterior pituitary, but it is still not known. The delay in diagnosis and also missed cases may have been because of symptoms of hypopituitarism which are quite non-specific and insidious, and especially in elderly, they may be similar to age-related changes, and also they may be like any chronic ailments. The frequent hypopituitary symptoms which occur are fatigue, weight loss, appetite loss, amenorrhea, reduced libido, infertility, cold intolerance, and loss of axillary and pubic hair, which presents quite late, as well as breast atrophy. So acute pituitary hypopituitarism is a rare complication, but it's probably more missed complication. This 30-year-old post snakebite had hematemesis with hypotension. The whole blood clotting time, a marker of DIC, was prolonged. The urine output decreased, and the patient had AKI requiring peritoneal dialysis. There were recurrent episodes of hypoglycemia. So this is very, very important. And that led to confusion, GTCase, tremor, and there was persistent hypotension. That led to investigation of cortisol, which was low, with low ACTH and low thyroid, free T4 and free T3. The PT-APTT was prolonged. The platelet count was also decreased. This recurrent hypoglycemia, hypotension, and shock are very important indicators of acute hypopituitarism. Very importantly, the pituitary MRI may be normal, as was found in this patient, but it is very important to remember this acute hypopituitarism is mostly persistent and rarely transient. And in a lot of patients, probably it is missed because we are only picking up patients who are symptomatic, and that too, a lot of them are being missed. And generally, we need to be doing more of dynamic testing even in asymptomatic patients. So what are the risk factors which should prompt investigations for acute hypopituitarism, which can occur within 2 to 14 days? And this can be because of severe envenomation with multiple organ dysfunction, decreased platelet, and bleeding. But very importantly, probably the most important accompanying feature is acute kidney injury, acute renal failure, and DIC. And if there is persistent unexplained hypotension and hypoglycemia, which can lead to confusion, these are also important indicators. Pituitary hemorrhage on MRI is an important indicator. And as sir was discussing, in adrenal hemorrhage, one can have pain abdomen, hypotension, and also hyponatremia with hyperkalemia. So this was a very elegant study which was published by IPGMR and SSKM Hospital, Kolkata, in Pituitary 2019, where they evaluated prospectively patients with snakebite having acute kidney injury requiring hemodialysis, how the factors which predict hypopituitarism. So all patients were tested irrespective of symptoms. Hypopituitarism developed very early in 20% of patients, and most of them were diagnosed at baseline. Cortisol deficiency was the commonest, but some rare patients develop even central DI and after cortisol replacement. And hypopituitarism was mainly predicted by patients who required more sessions of hemodialysis and who had initial prolonged whole blood clotting time at presentation. So we should be suspicious of hypopituitarism, acute hypopituitarism, in patients who have hypotension, unexplained hypoglycemia, and renal impairment, AKI, and a serum cortisol less than 3 baseline or even 10 may be helpful, or cosintropin stimulated cortisol less than 18 micrograms per dl may be helpful. And as we can see, there is more number of patients detected later on because of progressive damage to the pituitary gland as well. So identification of hypocortisolism is the most important factor in hypopituitarism, and in resource limited settings, as occurs in snakebite, random cortisol less than 10 in critically ill patients may be helpful as per the other Sirki guidelines. And similarly, the delta cortisol, that is increase in cortisol after 60 minutes, less than 9, also suggest hypocortisolism. The WHO guidelines suggest and advocate IV hydrocortisone, not IM, in unresponsive hypotension, of course, after taking cortisol samples and then shifting to glucocorticoids once patients are stable. In secondary hypocortisolism, if it is documented along with a low free T4 and T3, we should be starting medications, thyroid medications as well. Evaluation of gonadal and growth hormone axis should be deferred until the patient is stable after 6 to 8 weeks, when we should also try to confirm the presence of reconfirm the presence of secondary hypocortisolism and hypothyroidism as well. But there are some factors which hinder assessment, like critical care, critical illness related pituitary dysfunction, sick euthyroid syndrome, which is very common differential, especially in absence of hypocortisolism. Similarly, hypogonadism in acute illness, and very commonly prior glucocorticoid injection. So the reports may not be interpretable, and also possible pre-existing pituitary or adrenal dysfunction. So again, delayed hypopituitarism may occur after viral envenomation. This may be a continuum of the clinically overt or occult acute pituitary damage, but it may not be preceded by acute pituitary dysfunction. It is actually insidious onset, subtle and non-specific, and can be detected, as we have discussed, even up to 8 to 10 years after snake bite. So that is very important to take the history. And fatigue, weight loss, loss of appetite are general non-specific symptoms. One can have decreased libido and secondary amenorrhea in women. Panhypopituitarism is seen in 80%, hypothyroidism and hypogonadism in majority, along with hypocortisolism even in 75%. What is very important is, though MRI picks up empty cella in 60 to 75% of patients, even with delayed chronic hypopituitarism, MRI is normal in 25%. This is a very important differentiating feature from Sheehan syndrome, where majority of patients have abnormal MRI. And there is no correlation between empty cella and severity of hormonal deficit. Most patients have normal cellular MRI in the first year, as similar to Sheehan. There can be a non-hemorrhagic enlarged pituitary with a thin rim of enhancement. Then the pituitary subsequently atrophies, as we have seen, to an atrophic empty cella by 6 months to 1 year. What is not clear is whether to repeat an MRI after an acute hypopituitarism. And even in chronic hypopituitarism, MRI may not be universally abnormal, though in about 70% one may have empty cella. One may also detect old hemorrhage, and in presence of DI as well, there can be loss of posterior pituitary bright spot. Diabetes insipidus is very rare. This is because anterior pituitary is supplied by low pressure superior hypophyseal artery, which is generally susceptible to compression by increased intracellular pressure, which is seen with capillary leak and DIC. But this may not be sufficient to compress the posterior pituitary arterial supply, which receives a direct arterial supply from the hypophyseal artery. So polyuria is an indicator of DI, but may be only manifest after we correct hypocortisolism. Generally, it is accompanied, DI is accompanied by, as in this man of 20 years, with hypopituitarism and growth retardation and hypothyroidism and hypocortisolism. But rarely isolated central diabetes insipidus have been reported with normal anterior pituitary hormones, and there can be isolated loss of posterior pituitary bright spot with a lower infundibulous stalk atrophy with a normal anterior pituitary imaging. Now, moving on to adrenal insufficiency, this 28-year-old man presented with sudden lower abdominal pain, vomiting, and refractory hypotension. On 4th day after bite, hyponatremia and hyperkalemia was present, and there was documented low cortisol and high ACTH. One very important factor is the diagnosis of adrenal insufficiency is much rarer, but it can be missed in the presence of hypopituitarism. And CT revealed, as you can see, bilateral enlarged adrenal with increased density, suggesting bilateral adrenal hemorrhage, which can occur because of DIC, bleeding, as well as circulatory shock. And autopsy studies showed again in patients who have AKI, very important. AKI is a very important indicator for hormonal problems. Adrenal hemorrhage was seen in 36%, pituitary hemorrhage in 43%. Again, adrenal gland is highly vascular, and this etiology of hemorrhage and necrosis is similar to the Waterhouse-Friderichsen syndrome, where adrenal glands are supplied by numerous arteries but drained by a single vein. And so once there is arteriolar dilatation, followed by pooling of blood without adequate drainage because of thrombosis, there can be increased pressure leading to hemorrhage. There have been also reports of combined adrenal as well as pituitary apoplexy as well. Dysglycemia after snake bite is generally seen both in adults and pediatric population, related to degree of envenomation, and it is generally transient, and this is mainly because of autonomic storm with massive outpouring of catecholamines and increase in glucagon and cortisol level. Hyponatremia in hypopituitarism is all well known because of hypocortisolism and hypothyroidism, whereas it is also documented in 40% of crate, that is neurotoxic victims. And if fluid restriction is done, it was observed there was severe dehydration. And what was observed along with hyponatremia, there is decrease in serum osmolarity and increase in urine osmolarity with appropriately low ADH level. So in neurotoxic snake bite, this is basically not SIADH. This is because of direct effect of natriuretic peptides causing hyponatremia. And it has been seen that venom natriuretic peptides have higher potency and stability, and normal saline infusions are required. And this hyponatremia usually occurs by second and third day, and there is raised urinary sodium. But if we are not confident about the chronic hyponatremia, which is more than 48 hours, then slow correction of sodium is essential. Hypokalemia also can occur as a complication of neurotoxic envenomation, which can also complicate the weakness associated with muscle weakness associated with neurotoxic snake bite, which has been reported in Sri Lanka in 71% patients. This can be because of beta adrenergic stimulation from autonomic dysfunction and leading to intracellular shift of potassium, similar to hypokalemic periodic paralysis. And again, there is a potential risk of rebound hyperkalemia later on. And finally, hyperkalemia because of low acute and can present with acute lower limb weakness after viper bite, and this may be associated with mild renal dysfunction, normal anion gap acidosis with inappropriately low urine transtubular potassium gradient, and they respond to fludrocortisone, but fludrocortisone requirement decreases over time, leading to complete recovery. There have been documented cases of hyperkalemia during polyuric phase. This is something which we must be very careful. If we think in polyuric phase there is hyperkalemia will not be there, but it can occur out here, and they may require even dialysis with normal anion gap metabolic acidosis. But the mechanism is still not clear, whether it is because of the venom or because of AKI. Now, the future direction is what we need to investigate is whether early anti-venom administration, as we are all aware, decreases coagulopathy, capillary release, and DIC. Whether this early use of anti-venom can decrease the occurrence of acute or chronic hypopituitarism, that needs to be investigated. We need to investigate whether early glucocorticoid in refractory shock in snake bite is beneficial. And because, a lot of patients are in rural areas, so that is very important. We need to recognize chronic hypopituitarism early because that is associated with significant mortality and morbidity if they are untreated. Pathogenesis of electrolyte disorders and especially long-term pituitary autoimmunity needs to be determined because they are more speculative. And very important, advances in venom sequencing and next generation proteomics may help to identify venom components that can particularly, we can pinpoint these clinical complications. So in conclusion, acute pituitary adrenal insufficiency, hyperglycemia, hyponatremia, hypokalemia are emergencies. which we need to be always keep an eye on in snake bite from endocrine perspective. Pituitary is by far the commonest gland, but adrenal gland is though rare, but rarely affected, but is still important. And adrenal hemorrhage can lead to adrenal insufficiency, and especially patients present with pain, abdomen, and intractable hypotension. We must remember most bites occur in poor, remote, rural areas, so confirmation of diagnosis may not be always possible. So early initiation of empiric steroid, and we can keep the blood before starting the steroid and for proper evaluation. Especially, it may be life-saving in patients who have acute hypotension and hypoglycemia, suggesting acute pituitary insufficiency. If polyuria develops after steroid, we need to screen for diabetes insipidus as well. Very importantly, in long-standing patients, this is what they come to us with, that is symptoms of delayed hypopituitarism, as we have seen in this presenting case with coming with secondary amenorrhea. They may be very non-specific, suggest chronic ill health. So we need to screen them irrespective of symptoms. And this needs to be, we need to focus on patients, especially those who have developed acute kidney injury, bleeding, and those require a number of hemodialysis sessions, and especially those who have an abnormal whole blood clotting time suggesting DIC at presentation. It is very important to follow them up long term, because as we have seen in Sheehan syndrome, the pituitary damage may be progressive, and there can be new hormonal deficiencies, and this may lead to significantly increased morbidity and impaired quality of life. Very important, falling back only on imaging, that's a very important caveat, may be misleading, because even in chronic hypopituitarism, the pituitary imaging may be normal. So being aware and spreading the awareness of endocrine complications post snake bite is very important. Especially this has to be spread to the periphery levels, because that is where the snake bite and its complications occur. Thank you very much.